All right, let me just double check that we are live. All right, Chairman Harrell, we are now live and you have the floor.
I'd like to welcome everyone to the April meeting for the Pitt County Board of Health. We'll go ahead and call the meeting to order and take roll call with Ms. Betsy Wallace.
Adam Harrell.
Present.
Tina Dixon.
Present.
Martha Engelke.
Present.
Rex Fleming.
Present.
Herbert Garrison.
Present.
Mark Hayes. Scott McIntosh.
Present.
Natish Patidar.
Present.
Kelly Pack Smith.
Present.
Lowell Spate. Alex Albright.
Here.
Thank you. We have quorum.
We'll move on to public comments, and we have Ms. Diane Carden-Glenn representing Eckham for Change.
Okay, hi, my name's Diane Carden-Glenn, and I'm the founder of Eckham for Change. It's a syringe service program in Greenville that's totally staffed by volunteers, and we have an advisory board made up of people with lived experience to help us evaluate our program. I wanted to first thank you for supporting Eckham's efforts to reach out to the underserved community in Pitt County and provide them with options for a healthier life. I spoke about a year ago about Eckham and the syringe and needle exchange here. And this year, I'd kind of like to tell you how Eckham continues to serve the community in that capacity, as well as more than a syringe exchange program. So I'm just going to start out with kind of how we have dealt with COVID. So our participants are at high risk for infectious disease. Mostly because that they don't have fixed housing and live in groups. And so even with the effects of COVID, we were able to continue to provide services to our participants, first through a personal delivery program, and now through a combination of both delivery and direct services at our fixed site. Each participant is required to wear a mask. They can bring theirs or we provide one to them. They social distance 3 feet apart now, and inside the actual facility, they come in 2 at a time so that we can meet their needs unless it's a family, and then they can all come in at one time. The participants are now in group 4 and eligible to receive the COVID-19 vaccine. And we hope to be able to provide at some point in the future the vaccine directly through the exchange, since transportation is a barrier for many who are homeless and ride bicycles, or their only transportation is to walk. Next week, we'll begin to provide at-home COVID-19 test kits that were provided to us by the health department. We've been collaborating with Vidant for several months in an effort to advocate for participants who've been admitted and provide follow-up in an effort to decrease AMA discharges and readmissions at that facility. So each Thursday, I'm provided with a list of patients who meet our criteria. And then I actually met with the first inpatient participant last week who agreed to meet with me. And he was at risk for leaving AMA, and it resulted in a positive outcome. We talked about options for him going forward, and I'm going to visit him weekly until his discharge and then follow up if he wishes afterwards. We'll also be providing at the discretion of the social worker postcard-sized information documents for patients who present to the ED either from overdose or wound infections and are discharged the same day, so they can follow up if they wish with Eckham for naloxone, referral to treatment, and or other supporting supplies. We've been looking quite a while at using the arts or writing as a therapeutic intervention. And so we're now preparing for a pilot project in collaboration collaboration with ECU Collegiate Recovery and some other local organizations using the arts as a tool for therapeutic intervention for people who use drugs. A New York artist and a friend of mine who's also an ECU alumnus is going to facilitate the project for us, and it'll be displayed to the community at the university on August 31st, which is Overdose Awareness Day, and then we'll continue through the month of September, which is Recovery Month. We're hoping that this will be a successful way to encourage participants to use art to make some healthy choices and or to address root causes of their substance use, and also an educational opportunity for the public who'll be able to participate at the showing if they wish. If this is successful, it's something that will continue every year at ECHM. One of our goals this last grant period was to look at reducing infections. So ECHM participated in a UNC study of 5 syringe service programs across the state, investigating the occurrence of skin and soft tissue infections and endocarditis among people who inject drugs. The data is being used to assist us in our efforts to reduce skin and soft tissue infections and was instrumental in initiating our collaboration with Vidant that I mentioned before. So in keeping with our goal of reducing infections among our participants, we also received notification from ECU IRB approving our own study to provide one-on-one education to participants in an effort to reduce the risk of infection through improving safe injection practices. So our study began last week, and we began to collect data and educate the participants using a video and then asking follow-up questions. We're going to follow up with, we're hoping to have between 30 and 40 people in the study, and then we'll follow up in 1 month after each person's visits to determine if this medical issue with education was impactful. We do hand out wound care kits to help people that come in with abscesses in one thing or another, and we're hoping to see a reduction in that, as well as a reduction in visits to the ED for people who have wound infections. Another goal was to address hepatitis among our participants, as they're identified as a high-risk population for HIV and hepatitis C. So ECHM has been approved just recently by the state as a site for hepatitis C and HIV testing. So with this approval, we'll be receiving the rapid tests at no charge, and we used to have to pay for them. And in return, we just have to provide them with the data. So with the help of Gilead, we're now able to provide medical care for those participants who test positive for hepatitis C on a sliding scale within an hour's distance of Greenville. So we provide transportation when folks don't have it. And so far, we've referred 2 participants to either the Wilson or the Tarboro locations. One of the 2 candidates agreed to participate in the treatment program at the Wilson location as well. So for hepatitis C, the World Health Organization set a goal of reducing hepatitis deaths worldwide by 65% in the year 2030. So May is Hepatitis C Awareness Month in this country, and July 28th is World Hepatitis Day worldwide. And we're planning a public medical educational campaign and testing for one of these 2 dates in an effort to reduce hepatitis in Pitt County. So once COVID is less than an issue, we'll be working with the health department to provide hepatitis A vaccine to our participants. Last year, the health department staff provided flu shots for more than 30 of our participants at our fixed site, and it was we felt like it was really successful. So in order to kind of give you an idea of what happens, the number of people we see and what they do at the exchange, I'm just going to take a minute to share some numbers. Sometimes that's really boring, but so we have more than 900 participants that are registered. So the first 9 months of this year's grant, we provided services to 690 individual participants with a total of 3,110 contacts. We gave out 89,821 new needles, and we collected 35,825, which is about 40%, which is much higher than the average syringe exchange program in North Carolina. And those were disposed of at the health department. We distribute 699 naloxone kits. There's 2 doses per kit. And the reversals reported to us from that distribution from people who did not call 911 or did not go to the emergency room was 230. And they advised that they had to use at least both vials in order to reverse the overdose, and sometimes had to use a third or a fourth one. That same 9 months, we lost 17 participants to overdose, and we assisted more than 30 to some form of recovery, whether it was inpatient, long-term, a medicated assisted treatment, one of those. We see between 90 and 130 participants at the fixed site each Saturday. And so I'll just use last Saturday as an example. We saw 103 participants. 44 of those participants got needles. 2 of them were diabetic. We do have a few folks who come that are diabetic and can't afford their syringes, so they come and get them from us. So 57 participants did not inject their drug, and of the remaining were those who were homeless, living in a vehicle or tent, in a shelter, in recovery, or had some other extenuating circumstances. Of those who injected their drug, there were an equal number of men and women, so there were 22 of each. And the average age was 40. Of the remaining participants, they were largely male, and the average age is 38. And the population we served last Saturday was 2 Hispanic, 47 Caucasian, 52 African American, and 2 American Indians. So those are just kind of an idea of what we see at the exchange every Saturday. And we've never been able to be this successful, see this many people, and provide as many services if it wasn't with the full support of the health department and its board. And we thank you again and again. And I'll be happy to answer any questions.
Thank you, Ms. Cardington, for that info and your efforts. Any comments or questions from the board members?
I'm just stunned by how much you've grown. I was on the board when you first started, and how you were really a very small operation. And so I just want to commend you for you're obviously providing a service that's valued by these vulnerable people.
Thank you. And we do grow every week. And there's more and more of a need, we all know. But thank you.
Other questions or comments from the board? All right, thank you, Ms. Cardington.
Okay. Thank you. Bye-bye. And I just have to figure out how to excuse myself.
And seeing no other public comments, we'll move on to the minutes from the March meeting. They've been previously circulated to the board members. Any changes or additions from the board on the March minutes? All right, seeing none, we'll look for a motion to approve.
So move. Second.
Any opposed? All right, pass. We'll move on to the fiscal report with Ms. Marcia Hall.
Hope everybody's doing well tonight. Let's see if I can share my screen. Well, let me back up. Sorry, y'all, I'm not used to the screen being shared. Let's see if I can see it now. No. Well, I'm having some technical difficulties pulling up this, my report. My apologies.
I think you got it now, Marcia.
Can you see it?
Yeah.
All right. Well, it's hard. I am screen sharing. Okay. So are y'all able to see the financial report for the ending in March 31st, 2021?
I think we're looking at your other screen, Marcia. We're looking at
Oh.
your files.
Oh, well, that is why I cannot get it pulled up. It will not allow me. I promise you I've done it. I promise.
Hey, Marsha, can you hear me?
Yes.
We're going to go ahead and pull it up on the podium for you, okay?
Okay, great. Thank you.
No problem. So you said the Board of Health report is the first one?
Yes, ma'am.
All right. We got that pulled up, so go right ahead.
Okay, great. Thank you. So this is period 9, and we had a budget amendment of $519,475. This is the first of 2 COVID. Well, it's not first of 2, but it's AA 543, which brought our overall budget up to $13,879,160. If you look at it from a year to date, we are sitting okay. When you think about our time and items as we move across this report, our year to date, we have a surplus of $739,168. I just wanted to talk to you tonight about the variance, the pro rata and the actual. The top number that we are a negative amount, the $90,397. In the past year of COVID, that's expected. You know, our clinic services are operating at a minimum. Our clinic fees, as you go down this list, it's a minimum. The state funding line that looks like it's a negative $689,597. I want to point out that in the beginning of the fiscal year and today, we have received over $1.5 million in COVID funding. And when that money, well, not just COVID funding, let me back up, state funding. So it looks like we are under there. However, we cannot pull this money down unless we spend it. So it comes in the after months. So I just wanted to make sure everybody was understood. So as expenses come through, like for the instance of the month of March, I can only pull down in April what was spent in March. So there is a surplus of state funds that we are trying to spend. However, low inventory, delayed shipping. Some of our programs had surplus of money because of the no travel. That it's kind of worrisome, but it's not there's just surplus of money. The county funding that should regulate next month at the quarterly payment. And then the other, you will see this decrease as the year goes, just because we are a month behind with invoicing. But overall, we're looking pretty good with a surplus year to date adjusted at $739,000. Does anybody have any questions?
Any questions from the board? You want us to go ahead and take action on this, Marcia, before your next point?
We can, yeah, absolutely.
All right, we'll look for an action motion to approve the fiscal report.
So moved.
Second.
Any opposed? All right, the fiscal report passes. And now Marcia also has another item on the budget request.
Yes, it's the best time of year. It's budget time. I think I'm able to share my screen on this one. Now, are y'all able to see Pitt County Public Health fiscal year 22 Board of Health?
Yes.
Okay. So you received this. It is quite lengthy, but I wanted to be transparent with everything that's going on. 38 pages. Dr. Silvernell and I met with the county manager and the finance team on March 30th just to talk about how our request was going to go this year. Since that meeting, there's things, I call it the song and dance, because the county office has to start tweaking numbers and figuring out if there's going to be a COLA or insurance increase. And since that date, there has been a health insurance increase. So as you go through, we have a memo in the beginning that overall budget request was $13,590,753. However, as we do the song and dance the past few weeks, that number has already increased with the health insurance increase. It's a $15 per person. That's already up to $13,658,308. So the big thing we want to take away is where we were at the beginning of this fiscal year and where we are now. There's been a lot of influx of money. So it's hard to go back and look historically. You know, every year we say, okay, this is an increase of county funds that we're asking for because of this and this and this. But the increase of county funds that we're really asking for, it equates into pay for performance and health insurance mainly. And we are requesting 9 new positions. And out of those 9 new positions, 3 are environmental on-site positions that are desperately needed to maintain status quo of all the construction that is going on in Pitt County. You can't go more than a block and see it. And the other positions are personal health division. As you flip through the 38 pages, you see each position and the detailed justification for all of these positions. When we met with the county manager, we discussed this. I think you're supposed to hear more about positions tonight as well, but the overall budget, 78% of our budget is position personnel and fringe. As we scroll through, let me keep scrolling. I'm sorry. So these are the 9 positions. We've got the 6 positions total, personal health, and the 3 for environmental health. And included in our overall budget, the COVID funds, $248,000 is COVID funding for regional prevention. One of the items that is going to be an iffy situation is Medicaid transformation, which is for the 3rd time back into discussion. Supposedly July 1, there will be Medicaid transformation. We've been looking at the porch side talks and all the information coming out. There's still a lot more questions than there are answers. I did budget $50,000 to offset some of these costs. I know there'll be costs. We just don't know what, and I don't know. That's a moving target. As we keep pulling through this memo, we are asking for the 0.50 FTE that has historically the past few years offset our diabetes self-management position. We also included the 2.80 positions for the Healthy Beginnings grant that ended year before last. They really hit the ground running, and then COVID hit. The overall ask is not much for those 2 because it's a 1.60 total. As we keep rolling through this memo, pre-COVID, we had our CIP project, which turned our medical records into office space, which if you keep going into this huge packet, you'll see the plans. That was approved last fiscal year. However, it's back on the docket with a $50,000 increase due to the construction cost of how things are just have increased astronomically. We also have spoken, some of the lapsed salary dollars that we've had this year, we're trying to use very frugally and buy a truck for environmental health this fiscal year. Smile Safari unit, also, if you saw that, that is out in the CIP for the next 2 years. It's over 20 years old. We're looking at trying to replace that in fiscal year 23. So this was the memo that was sent to Scott that we just talked about some things. I told him that after this meeting tonight, we might be going back with him with some more things that you suggest. But every year we send you what each program, and we'll see if I can change that view. I'm not sure if I can or not. These are our programs, and you will be able to see if they get state funds, county funds, the different funding source. And at the very bottom, I might have been kind of detailed, but this is where the increases come per program. And this kind of breaks it down. The health department, we run on programs. Admin usually covers a lot of things that don't necessarily get certain pots of money. So I'm going to keep scrolling, and feel free if you've got any questions to jump in. These are some of our other programs. And as you see the color, the county funding, we're going to get to that in just a minute. So here we've got where it ends up. Overall, the county ask is 6.966301. And we've broken that down by the projected. So county appropriations, admin, a little over 2 million, environmental health 1.6, our clinic 2.3, outreach 491,000, our dental unit 163,000, and WIC 297,000. So this is the county portion for the health department. And I'd like to point out that in the admin, that 2 million, that is also offsetting about 200,000 in salaries for our lab personnel and our contracts, and also our medical records and interpreters are budgeted in the admin. And as we keep unpacking this, I'm going to change this view. Whoop, wrong way. Well, y'all, that's not good. Oh, wait a minute. I apologize. Let's see. Okay, overall, our projected budget summary is that 3.9 is coming from the federal and state, 1.4 is coming from Medicaid, 259,000 fees. The other is 480,000. That would be grants and contracts that we have. We always budget some of our fund balance. The past few years, we've not had to use that. And the county ask is 51%, 6.966301. That has been in line with the past few years. As you can see, overall, our personnel and fringe is 78%, and operating is not quite 22%. I can honestly say these programs are doing a lot with little. So $2 million admin looks like a lot of money, but this is a detail on what flows in and out of admin. We have a lot of our contracts, Diane's program, the school nurse program, that's $250,000. We have the COVID funds, the $248,000 that I mentioned earlier. This is just some detail on where those funds are going. A lot of things are charged in admin and then redistributed back to the programs like WIC and all these programs that can pay for mail, telephone, cell phones, utilities. We charge it back to the different programs. Okay, I'm gonna try to get this right the first time, y'all. Sorry. Okay, so that's 78% of, oh no. I don't know what just happened.
Marsha, can you hear me?
Yeah.
What page are you on? I can pick up.
I'm on page, maybe page 10. It was the benefit calculation rates.
10, you said?
Yes, ma'am. Thank you, Carla.
Can you see it?
Oh, Tina says page 12.
Page 12, thank you. Ryan, make sure you're sharing the podium, please.
Oh, great. Okay. So this is the tentative personnel calculation rates. And as you can see, the retirement is 11.4. And from what I was told, this was a catch-up year for the state. And that can really run havoc on a personnel budget. And also the insurance is increased to $710 a month since this actually came out for budgeting. And Carla, are you able to start scrolling? Oh, wait a minute, am I scrolling? This was the capital improvement plan that we spoke about. This was actually from last year. I just put this in here just so that you could see the CIP projects for the medical records and for the Smile Safari. We can keep scrolling. This is the medical records drawing of adding the 4 offices. We still have 2 sections of paper records that we're still working through, scanning in. It was just not cost effective to scan all of those in. We're doing that as clients walk in the door. And this is, can we get that turned clockwise? Perfect. So these are the positions and how they end up breaking out over in the different programs and the benefits. I wanted to show this to you in detail and how that increased the county ask. Overall, all of these positions, the ask is $679,042. And what I do want to point out, although this looks like a lot of money, all of these positions will be bringing in revenue somehow. It may not be the first day they start, but after they're trained, there is a, we can bill for some of the services that these nurses are seeing in the clinic, and the environmental health specialists, for the subdivisions, the work that needs to be done, and the permits and the recheck. So they will be generating some of the money to sustain these positions. Thank you. And as you keep scrolling, these are the detailed information about the budget requests. I'm glad I'm not the only one that flips that around. That were provided by Personal Health and Angie Manning, our Environmental Health Director, who's here with us. So if you have any questions about the positions in detail, I can, they might can help join me and answer them, or I can find those questions for you. The personal health nurse positions, I just want to say we've got some very close to retirement, at least 2 or 3 that are within 2 or 3 years, and we really need to hire to get them trained, all that knowledge walking out the door. And we can keep scrolling through these. I wanted to show, there's quite a few of them. And in the very end, the budget workshop that we will be presenting, Dr. Silvernail will be presenting to the Board of Commissioners, is on Tuesday, May the 4th at 8:30. It is via Zoom, so you all can join in. And the last page is the agreement addendas that are our state and federal funding. There's quite a few of these, and they come pretty quickly, and they can change at any time. So if you've got a program going smooth, the state can come in and say, hey, we got to take $7,000 away, or we're going to give you $100,000 more. So for the most part, no programs got a decrease in funding. I did not see that across the board. I do wanted to point out the very bottom of this is HIV PrEP and Triple P Positive Parenting Program. These programs are in grant numbers, and those grant funds are in that grant report. They are not in our overall budget, but I feel like $500,000, is a substantial amount of money that we need to bring to your attention. And those are AAs that we get from the state. But I know that was a lot of information. This budget has been very interesting after living through COVID. A lot of our programs that have a shoestring budget, last spring when they cut travel, they were able to buy things that they had normally not been able to. And even this year, they've been able to The state consultants have worked with our employees, and they've been able to do a lot of creative things, providing things to clients. So it's been great to see them work within those challenges. But I think they're doing a lot of good work, and no one's here is asking for anything. I think we're all too exhausted to ask for anything too outrageous. As you can see, it's a very small, minimal operating budget. So who has questions for me?
Marcia, I was noticing on the agenda that this approval of the budget is an action item.
It is.
Do we need to do that tonight, or do you think we need to listen to what Ms. Hardy has to say on her piece?
I'm happy to do however you want to do it. I'll be here all night. So however you want to.
Okay. If we're anticipating change, then I don't know that we should approve it tonight unless other board members feel differently.
Absolutely.
Any questions from the board members or comments?
Yeah, I had a question.
Yeah.
Commissioner Albright. Yeah, I'm wondering if you could help us figure, especially with the environmental on-site inspections, if those 3 positions are up and running full time, is there a way to estimate the amount of income they would be generating as a way of balancing off this request? I look forward to doing what we can and hope that you would get the entire amount. But especially in our last meeting, that seemed to be an effective argument that Sheriff Dance brought when she was requesting 3 additional positions. The idea that those positions were bringing in a certain amount of funds with a person working full time. And it seems to me, and I may be wrong, but that might be more that might be more the case with the environmental on site than it would be for the 6 personal health positions. That is, you might not be able to anticipate the revenue that they would be generating so much.
Correct.
It doesn't have to be tonight. I'm suggesting that might be something that Dr. Silvernail would mention when he presents his budget on May 4th to the commissioners. It's not a question that I need resolved, but I think it would be helpful in your request.
Correct. Yeah, I really, Angela, you can feel like jumping in if you want to.
I'll be glad to. I wish I could, I had a projected that I could. I think those positions are more of a value add for the developers and builders in their turnaround time. When you have one employee who is doing subdivisions and you look at the development time where one employee might take 3 months to do a development lot, where a developer is trying to get a 55 lot subdivision through the planning and development process of Pitt County as a whole. Time is money in that sense. And so I don't necessarily know that we can necessarily equate that. These positions really are to account for almost 3 years worth of growth that have not been accounted for in the environmental health section. In that, according to the manpower study numbers that I did. And so in that type of sense, I don't know that we can necessarily make that same argument for these positions. These positions, in all honesty, are really needed for the day-to-day operations are really, we're at beyond maximum capacity.
Yes, I think we understand that in the county. So what you're saying then is that with the addition of these three positions, we still would not see an increase in.
Right, we're able to produce.
Okay, thank you for that clarification. Thank you.
Other questions from the board for Marcia? In the interest of time, do we want to take a vote on this now? Because I think even if we had change, I don't know that we'll be able to get it into the budget for tonight in lieu of Dr. Silvernail's May 4th meeting with the commissioners. I need some input.
I agree. I think we just approve it subject to modification as we go forward.
I think that's what's the only way we're going to be able to do it, Dr. Hedges.
I make a motion we approve the budget as presented, the projected budget.
I second it.
Any opposed? All right, the proposed budget passes. Next, we'll move on to some items of old business with the salary classification study with Ms. Florida Hardy.
Good evening.
Good evening.
I think you all have the document. I believe Betsy has the document, has provided it to you all, or will provide it to you.
Mhm.
Yes?
Yes.
Okay. So basically, just a brief overview of how we arrive at the percentages that you have in your document. With the county classification studies, we're typically, and we do them each year for Pitt County government positions that are non-human services positions. So what we're looking for when we are comparing to other counties and entities is Pitt County, we decided we wanted to be at least within 5% of the base salaries with counties that we could compare to, which are similar in population size, budget size, so those types of things. So we want to be within 5% of that. So when we find positions that are not within 5%, typically we would be requesting a pay grade change for those positions, and which raises the base salary. So that is the way we would do it on the county side. With the human services agencies, as you're aware, we don't have the authority to change the pay grades of positions. So the way the positions are set up, the state sets the pay grade, our Board of Commissioners sets the salaries within the pay grade. So that is set by our Board of Commissioners. So with that said, with the document that we have, what we did find, and we pulled all of your positions, I think the board wanted to look at not just nursing positions, but kind of get a bird's eye view of all the positions and overall look. Overall, base salaries were not so bad, not that far off. So the starting salaries that we have in place for most positions are in pretty good shape. We have a few outliers of positions that are fairly unique, like your health director, who's a physician and not an administrator. He's a physician in his position. So his position is fairly different from most of the other counties. What we did find, your starting salaries seem to be okay within. We have a few that are beyond that 5%, or less than that 5%, then maybe they're 8% below. If they, like I said, if it were a county position, we would be seeking a pay grade change. But with the starting salaries, we're fairly good. Actual salaries, we collect the data, but we don't make pay grade changes based on the actual salaries of employees who are in the position, because those change based on situations, person's longevity in the position, other factors, how our merit system set up in other counties. So which could create higher salaries across the counties we compare with. So we take an average of the comparatives, and that's what we actually compare against the actual salaries of our employees. We did find that you did have some positions that are deficient or less than the counties we compare to. So, and some of them not so much, some a small amount. What you will also notice is that in some positions, we did have a difficult time finding a match, simply because counties and everyone is structured very differently. You have some who are substantially equivalent. We have some who are consolidated human services. So they're structured a little bit differently. So in those counties, we did a lot of phone calls, research, pulling job descriptions to make sure we could find positions that were a pretty good match. But if you have the spreadsheet, I guess you can kind of see what positions we're talking about that are what you're looking for, those negative numbers, which means, and the first row on in each section is the starting salary. That's the base salary that's set up. And like I said, the base salaries are set within the county. So the commissioners, based on our pay classification pay plan, sets up the salary inside of each pay grade. The state actually sets the pay grade. So, and in my meeting last week with Dr. Silvernail and some of his other staff, we had lengthy discussions about some of the positions, how we recruit, what can we do to make the recruitment so we can be more effective, reach more folks who want to apply for jobs in Pitt County. One of the things we do find is with our nursing positions, the minimum qualification seems to be a hindrance, especially for your entry-level positions. They do have to have that public health nursing rotation to come in, I would say, fresh out of college just after receiving their BSN. So when they don't have that, they're not able to work for us in a full class until they have that 1 year in. Unfortunately, by that time, they've gone to work for someone else and they're comfortable where they are. So recruiting them away from those entities is a challenge. That's kind of the basics of it. Since you wanted the data, we do have the data. And like I said, what you'd be looking for in this spreadsheet is where the positions are in the starting salary 5% below. And that's the average of the data that we collected for the other counties. And then the actual salary, you can see some of them, even on that very first row, we're very much below the actual salaries. And that would be an average of the positions that we studied in the other counties. With that said, I guess I'll leave it for questions if you have questions for me.
Any questions for Ms. Hardy?
Well, I have a question. Just what is the next step in these positions that are found to be deficient? Is there some sort of remediation that happens to the people that are in the positions, or does it change the amount of money that goes for recruiting for these deficient positions?
So as I mentioned, the pay grade we can't change. If you were general government, on the county side, we could change the pay grade. We don't have that luxury because the state sets the pay grade for the base salaries. Now you can, when offering positions, they do not have to come in at the base salary. So that would be up to Dr. Silvernail to determine when someone needs to be offered a salary above the base salary inside of the pay grade. So that's one possibility. The recruitment piece of it, we talked about that public health nursing rotation, maybe working with the state. What can we substitute for that 1 year of public health nursing rotation? That has been a challenge. They've not offered us anything. They did finally agree to, I think the hospital has some community outreach programs. So they would allow that as a substitute for the public health nursing rotation. But that's going to be the more higher level nursing positions like your public health nurse 3-level positions. So we continue recruiting, we reach those places, we reach out to those colleges that have that nursing rotation so we can recruit them straight out of college. And hopefully they can get used to public health and want to stay long enough to get to that 3-level so they will qualify for the 3-level. As far as the for the actual salaries of positions for those who are below, I think that might be more of what you're asking for. That would be up to you all on how you want to proceed with that. If you wanted to find a means to raise those actual salaries, they would be raised, I guess, inside of the pay grade that the persons are currently in. So that would be up to your board, how you all want, and Dr. Silvernail, how you all wanted to proceed with that. If you wanted to petition to start, ask for funds to raise those salaries. And this would be the actual salaries of the people who occupy these positions. But bringing them in higher in the pay grade is going to help with that to start with. If you can bring them in higher in the pay grade. The only caveat we do tell them to consider when they're going to do that is consider the folks who are already there. So if you have someone you're bringing in who has less experience than people you already have on staff, then that may not be a fair thing to do. If you have people already on staff and you bring them in at a higher salary than those people who are there and have the experience in public health. So one, determine how you want to raise those actual salaries. We work on recruiting as much as we can, have Dr. Silvernail and we, public health, and we reach out to Office of State Human Resources. And can they give us something to substitute for that 1 year public health rotation? We've not been very successful with that in the past. And we've talked about the fact that they've not reviewed these job descriptions, I think, in years, and the minimum qualification that goes with them for most positions under their care. The other caveat is we can petition the state we can ask them to raise a pay grade. We can request that, but it can't be, it has to be for an entire series of positions. So if you ask for, can we raise the pay grade for a public health nurse 3, you have to do the 1, 2, and the 3. the nursing supervisor. So you'd have to raise a pay grade equivalent for all those positions. So there is one way that it can be done to raise those pay grades, but we do have to petition the state to have that done. So, but you have to raise a pay grade for all positions in that series. So going forward, if you're talking about the actual salaries, the only way to do that right now, I guess, is you would, you petition, you get the actual salaries raised, but they would remain inside of their pay grade with taking that step.
I had one other question. Have you, I'm old, so I know a long time ago, some of us that are in public health, we did a course in public health that I think it was offered through AHAC. I guess that just doesn't exist anymore.
No, I'm sorry. This is Dr. Hardy. The course does exist. It's called Introduction to Principles and Practices for Public Health Nursing. I teach the course twice a year. I teach the first session of that course, and that course is offered for nurses who do not have a BSN degree. So nurses have ADN. That course is required for those nurses.
Okay. I thought I didn't dream it.
We typically lose the nurses. The salary range is wide. So when you look at the base salary and you look at the salary to the far right, we get candidates interested in the positions because the salary range is so broad. But it's, as Florida mentioned, when we go to offer the salary, which is usually on the lowest end of the scale, we lose them because we cannot offer the new nurses who are coming in the salary that is competitive with the market, because the salaries of the nurses who are already on board, it would not be good to offer the new people coming in higher than the nurses that are already employed.
So then the bottleneck is that you have to improve the salaries of the people that are already on staff.
Yes.
Well,
yes.
I hope that can be done. I don't know how to do it.
I hope so too.
Any other questions for Ms. Hardy from the board or comments?
Is there a way that we can see what positions are most in need to where we could raise salaries for what the health department needs, not across the board, but just if we need environmental health supervisor 1, 3, could we just raise those salaries, or does it have to be across the board?
For the environmental health, so if it's using that as an example, if you decided you wanted to change the pay grade, the state would have to change the whole series. If you're talking about the actual salaries of the employees in those positions, you could choose a level. If you were talking about the entry level environmental health specialist, if you wanted to raise the actual salaries, you could do that for that particular set of positions. But then they would be close to the next level, the environmental health program specialist. So it's like a ripple effect. So when you start raising, start bottom, you really have to look at the broad spectrum and look at all the positions. So the question is, and listening to Dr. Hardy, if what they're requesting when they come in is, I'll say increment 9, maybe on our pay scale, which is probably about 9% above, the base salary, then you would have to make sure that your nurses that are already there, that you keep that gap. If not, you create some salary compression for your much more experienced nurses and those coming in. So what we don't want is create salary compression and other factors that, that we make sure we look at, that it is a fair process, fair and equitable, considering the folks who are already in the positions. So there are some ways it can be done. And I would be glad to work with, Dr. Silvernail and the rest, if that's what you all want to do.
Florida?
Yes.
Is this a product of those many years that the staff did not get raises, where it has become a holding, like almost a holding pattern, so you can't recruit in? I guess that's where I'm trying to figure out how it went so far off the rails.
Yeah, that's a good question. And yes, that's part of the issue. When for 3 or 4 years, we were not getting COLAs. So we were not, and just because we couldn't, because of the way the economy was.
Right.
So our base salaries are raised when the board approves a cost of living raise. So whenever there's a cost of living raise, it goes on top of our base salary. So our base salaries are raised by that amount. So for those years, the base salaries were not being raised. But however, that was the issue across the state with other counties as well. So that's why we're not that far off with base salaries. The other thing that the county also had to do during that time frame is we froze the pay for performance process, which means actual salaries were not rising either. When we were able to reinstate it, when things got better, we just picked up and just went forward. So we were not able to catch up people who did not receive pay for performance for about 3 years.
Right.
So that did make the actual salaries a little bit stagnant. So and probably even created a little bit of salary compression, because
Correct.
we were bringing in new hires then who were coming in very close to those who had been there for a while.
Right.
They were not able to move on the pay scale during that time frame. So yes, that did contribute.
And another contribution to it, once you're here for a while, and once you get down, what is it, step 17?
Midpoint, yes.
Your pay for performance gets halved, right? It's like 1.3 versus
2.4.
2.4, which is another part of the equation that the longer you stay, if you were a senior staff, why you may not be on the higher end of the pay scale, correct? I just want to make sure.
That is correct. Excuse me. Once you hit increment 17, your progression does slow down. But if everyone is moving, I guess, at the same time in every year, then you should always be ahead of the people, the new hires coming in, unless we start bringing the new hires in at a much higher salary.
Correct.
So then that does create some issues. But I would assume if they're coming in at a much higher salary, then our thought process at this time is they have as much or near as much experience as the person who's already there in a similar job.
Right. Is there any discussion that that could be taken away, that somebody that has been here over the step 17 could get the performance at the higher rate? Is that something that the county could easily do to offset some of this?
You mean change the way the pay for performance is administered and those? Sure, it can be, that is it's an administrative policy approved by the board. So that would be something our board of commissioners would have to approve if we made a change in the pay for performance system.
Okay. And that's got to be across all departments, not just one department.
Yes.
Okay. Thank you.
Sounds like this is a information that's got two parts. As most industries, it's about recruiting, but it's about retention.
Yes.
And I think that both parts are equally important here, because what we can't afford is we can't afford to lose the people we have. And you're right, it's not fair to bring in new people and not reward the ones that are already here. So if you're going to move your salaries, that it's remarkable to me, the difference between starting and actual for some of these positions. It's no wonder we have a hard time filling some of these positions. We're not competitive. Now, there might be some benefits to working in public health or working in government work, but there's not a 20% difference in paid difference, I don't believe most people would say. So I think we really have to look hard at how can we get our salaries more in line within the private sector. We can be competitive, but not at such a big difference between the two.
I agree. And looking at the report that Ms. Hardy sent, I'm not as concerned about not getting a hire from, a nurse that might be interested in working in Union County. It's Vidant or, a private medical office. I think those are the ones that where we're seeing, most of those positions, they're still vacant for that reason. Other questions?
I guess the thing that also concerns me is it's fine to ask for new positions, but we have so many positions that are open. You wonder if instead of asking for more positions, we ought to sort of fortify the positions that we have and get those filled. I don't know the process. I don't know, Dr. Silvernail, if you could comment on does that make sense? And is it possible to do that?
That's exactly what the manager put to us in our budget meeting. If you've already got 7 vacancies, how can you fill 6 more? And part of it is, I think going back to OSP, that's going to be a long and tedious process through the health directors to go back to OSP, Office of State Personnel, and try and get some of these requirements adjusted for incoming nurses. We know in the past we had the College of Nursing students were at the health department as part of a rotation or a class. That has been changed or restructured somewhat, so they don't directly rotate with us like they used to. I mean, we still get some, but not to the degree that we used to. And it's nice to be able to kind of test drive some of these folks and then hire them. We do that a lot in environmental health, where we have environmental health interns, and if they're good folks, we try to recruit them and hire them for open positions in environmental health. I would mention environmental health was already upgraded. Positions were upgraded a couple of years ago in terms of classifications of positions to raise salaries in environmental health. We do struggle with our nurses where our base salary, as Florida said, matches pretty well, but the actual salary we tend to be behind on. And then we had 3 nurses. I guess we've hired 2 out of the 3 here, but all 3 nurses asked for the same salary in their counteroffer. So either they were coordinating or that number is where they feel the job is worth. And technically, we don't compare to Vidant because in the eyes of Office of State Personnel, our position is an equivalent to Vidant's position. So we don't compare salaries. Now we know in our market, a nurse doesn't care about what OSP says. The nurse cares about, well, I can get X at Vidant, or I can get X at ECU, I can get X at Physicians East or whatever practice in town. And this is what the health department's going to pay me. And if the other practice is going to pay me more, well, I'm going to go there. The other thing that we've kicked around internally is, do we always need to hire somebody full time? Do we need to create more of a supplemental or per diem pool, maybe a no benefits clause where we could pay somebody higher, a no benefits rate? And Florida's probably going to shoot me for this next time she sees me. There's some of these things that are done in the private sector that typically aren't done in government employment. We did this in one of our rescue squads, where if you came on the squad's benefit package, your salary was X plus benefits. If you didn't want the benefits, you could come work and we'd pay you so much more an hour for working without benefits. We'd give you that no benefit upgrade in your salary. We don't typically do that in government employment, but that's something to maybe consider. That would take Board of Commissioners action, I believe, to change something like that. So we are thinking about some of those things in terms of how to fill those positions, how to meet the need, and remodeling that division. Certainly we need full-time nurses, but perhaps we could get away with some folks that are willing to come in and give us 2 or 3 days a week and get that part of the work done that we need to do. It's about the mission, not necessarily about how we staff the mission sometimes.
Other questions or comments on this or for the party?
Commissioner Albright.
Good.
Okay, I'm sorry. Thank you. Yeah, it seems, excuse me, it seems like addressing the current inequities would be something that we could do locally, and that it might be something we would want to address rather quickly. And I know this is different from the academic life that I was used to, but certainly after 37 years, lots at ECU, many people were being hired at higher salary, more than what I was making, and that was part of how I accepted my position. But there was an active program every year that tried to address this salary compression, and it looked at those who had the most differential between what was being hired or what was being offered, and those salaries were brought up a little bit at a time, and it was an active program. It wasn't a one-time thing, and I'm not in any way suggesting that's what we need to do here, but it sounds like there might have been a period of time that's elapsed since this issue has been addressed within this area, and I think that it sounds pretty critical, and it looks pretty critical, as it's been pointed out, with some of these inequities.
I agree. Any response, Commissioner Albright?
Yeah, I think it would just be beneficial to identify the positions we need to retain the most, and maybe potentially raise those salaries if we can't do it across the board.
Other comments?
Well, I'm just wondering, is it the role of the board to make that as a recommendation or a strong support that we do support the ability of Dr. Silvernail and Dr. Hardy and the other staff to try to make, as Commissioner Albright said, if we could do that quickly before we get into this hiring time, it might give us a little bit more leeway with the hires. I guess I'm just saying is that as someone who really supports all you're trying to do, that I don't know if it would help for the board to endorse that.
So I think what I'm hearing is, do we need to prioritize what we have now? And make a list of what are we trying to accomplish first and most quickly, and then attack those positions and make them more attractive to, potential employees.
Mm-hmm. Would that be a motion, or is that just send it forward? Tina says yes.
Could I ask Florida, what is involved in this petition to address these inequities? How does that process work? Can you hear me, Florida?
Yes, I can. How does it work?
Yes.
So basically, your board, if they wanted support, what Dr. Silvernail is doing, and Dr. Silvernail then, I guess, petitions the Board of Commissioners. So identifying the positions that you want to work with, I do agree that would be probably the first step in the process. And create a plan on what is it you're trying to do and how would you like to proceed. You create a plan, and then that plan then goes to, I guess, between Dr. Silvernail and the county manager for discussion, and then it ends up with the Board of Commissioners.
Thank you.
So Florida, if I understand that, basically I would need to go to Scott and then to the commissioners with a proposal to raise the nursing salaries across the board by X% in the next budget year, essentially.
If that's what you wanted to do, the manager would like, if you would discuss with him, so at least he'll know what's going on, and we can take a look at it and make sure, that we're doing it in a manner that we're, I guess, being consistent in the way it's going to be managed going forward. And then he would have some information when you got ready to present it to the board that he could share with the board as well. So yes.
Yeah, Dr. Silvernail, I think I'm trying to talk about existing positions that's a more localized thing and would not require across the board action. And that's what I'm trying to suggest. I think what you're suggesting is certainly a good thing, but it seems like that more immediately, if we have these positions where the inequity is so great, and I thought I understood from Florida that was how we would petition. We would say these particular people are way down and these particular salaries need to be brought up, and it's not an across the board. Is that not right?
You could do it either way. If you want to petition for the certain positions that right now are seem to be unequal, where the positions are much lower then yes, you could target those first.
Okay, that's what I was trying to suggest, and whether we go with that or not, I just want to make clear that I think there were two paths that were being addressed here, and what I was trying to bring up was this existing person who is looking at a lower salary, and in order to justify the higher salary across the board, we would maybe want to raise that person's salary up so it wouldn't be quite as painful when that person saw the inequity. So
Yeah, that's what Tina's audio is out, but that's the same thing she was saying was, start with these most critical, the ones with the biggest negative discrepancy, attack those first, get them where they need to be, then take a step back and reprioritize everything that's left from there. I think that makes the most sense.
Yeah. And I will comment that actual salaries, of course, as you know, are a point in time. So if we did this same study, maybe a year or 2 years down the road, the numbers may look very different because people come and go in positions and salaries, the actual salaries change as personnel changes. So your lower actual salaries may be relative to people who are recent hires and have only been here a short time frame and came in at a lower salary. So just keep that in mind. It's a point in time. So when we collect the actual salary data, which is why we don't change pay grades based on actual salaries, we do it with the base salaries. But it's a point in time and it is based on so many different factors. The longevity in the position, what do the other counties that we're comparing to do? What do they do to raise actual salaries? What types of things do they have going on? Do they give large merit raises? So what is in place in these other counties that makes their actual salaries increase so much? So.
Okay, other discussion.
So could we get an update? Yes, maybe next meeting. I'm sorry if I'm talking out of turn. I was just seeing if we could get an update on this at our next meeting.
Yeah, I think that's reasonable.
Can I add, this is Dr. Regan. Can I just say one thing? I got an email today, and I just want to say that what we're facing is we're not alone across the state. Public health nursing is becoming extinct.
Sure.
And if we don't do something, we're at a critical, I've been saying this for about 8 years now. If we don't do something about our current state, you're going to look up and you're not going to have public health nurses. You're going to have nurses coming in to contract. And public health nursing truly is a specialty. And the public's health is directly impacted by the presence of nurses who are trained with public health principles and practices. So I think and Dr. Silvernail has been very supportive of our efforts to improve nursing presence within the health department. We have had quite a bit of turnover, and it makes one wonder if it's leadership, what is the problem here? But the work environment, when you have people who are constantly taking on the roles of those who leave, you get a workforce that's burnt out. And when a pandemic hits, we're not able to respond in a way that is optimal. We have been able to function in the way that we've done in terms of being able to complete over 9,000 COVID-19 tests in the county last year, and producing over 10,000 vaccinations since October because we have had our nursing staff supplemented by contractors. So that's not sustainable. And I appreciate this being discussed tonight. But across the state, across the country, this is an issue that's it's not special to Pitt County.
And Dr. Hardy, I remember you and I talked about this in a meeting 2 years ago with these openings. And, I just broke it down and said, look, we're talking about income producing positions that we're essentially leaving money on the table for our bottom line by not getting people in these positions. And that affects how we operate.
That's true. And the other thing that I'd like to say about this is primary prevention is cheap compared to tertiary prevention. So if we look at how much money we're actually spending in our county with patients who cannot get access to care with us because we don't have the nursing staff to provide those services and they're going to the emergency room, or if we look at the cost with infant mortality, poor prenatal maternal health outcomes, and poor infant outcomes, we are spending more money than we can actually visualize on these spreadsheets. And that's all I'm going to say. Thank y'all for considering this.
All right, other comments for the board before we move on? All right, any items of new business to discuss? Seeing none, we'll move on to the health director, Dr. Silverman.
Thank you, Dr. Harrell. Bring up my slides. Oops. Back to the top. I got that up. Sorry about that. I wonder if it would be appropriate, not that anybody needs another meeting, but to try to convene a summit on the nursing salaries. I think it'd be, well, yeah, I could say, let's go in and we'll look at these positions that are behind and raise them. After this past year and what our nurses have been through and what our nurses have done this past year in light of COVID, it'd be very hard for me as the health director to look my nursing force in the eye and say, you're getting a raise and you're not. So I would consider that in light of where we are from the standpoint of this year of COVID, the year plus of COVID that we have lived through and continue to live through, and the work that our nurses have done as a whole. As Dr. Hardy said, without our contractors, we would have failed. Our testing program would have failed. Our vaccination program would be a failure. Those programs have succeeded because we've had contract staff to supplement our full-time nursing force. So, with that being said, I'll move on to my report for the month. First, I want to say Happy Public Health Month. We decided that Public Health Week wasn't enough this year, and we are celebrating Public Health Month at Pitt County Health Department. So Happy Public Health Month to all of my staff at the Health Department. You guys are awesome, simply awesome. The J&J vaccine news. I'm going to move this up. Of course, this hit us all at anywhere from between 7:30 and 8:30 this morning when this broke in the national news, and CDC sent out information on this. And I'm sure you've all heard about this by now, but in the US, approximately 6.85 million doses have been given of the J&J vaccine. In the VAERS system, the Vaccine Adverse Events Reporting System, there are 6 reports of cerebral sinus thrombosis with low platelets. This is believed to be an autoimmune thrombotic event and a very rare type of blood clot event. This occurs in one of the cavernous sinuses that drain the blood away from our vein. These are generally high flow areas that don't often form blood clots. May makes 30 years since I graduated medical school. 4 years in medical school before that. In that 34 years of time, I've seen one of these in a young girl with a hypercoagulable syndrome. So a pretty rare occurrence. All of these cases that have been identified in the VAERS system are female. The age range is 18 to 48 years, so they seem to be in women of reproductive years. The onset of symptoms was 6 to 13 days after the receipt of vaccine, and there is one individual who has died from this condition. CDC, FDA, and the North Carolina Department of Health and Human Services recommended a pause in the use of J&J vaccine, and we have complied with that pause. The Advisory Committee on Immunization Practices, otherwise known as ACIP, will review the data in the emergency meeting tomorrow. So far, Pitt County Health Department has administered 485 doses of this vaccine, all more than 3 weeks ago, so we should be outside of the window for this to appear in anyone. And at this time, we are unaware that this complication has appeared in any of the individuals that we vaccinated. I might add that 6 and 6.85 million is about 0.87 per million individuals vaccinated. So a very, very rare occurrence of this, this complication, but it is out there. COVID-19, 1 year and counting. I wanted to do a little bit of a retrospective for you tonight. Last month, we were just before the 1 year anniversary of COVID. Tonight, we're just a couple of weeks after the 1 year anniversary of COVID. So I thought a retrospective of COVID and COVID response activities would be appropriate for your review this evening. So let's talk about our COVID-19 timeline. December through March, and novel coronavirus appears in Wuhan, China in December of 2019. There are some reports out there suggesting that it was there earlier, but officially it was first identified in December of 2019. This virus rapidly spreads around the world, eventually reaching the west coast of the United States. And in general, the virus moved from west to east across the US. There were sporadic cases here and there across the US in the early days of this. But for the most part, this virus and this pandemic kind of moved from west to east across the country. One of the things that I found interesting early on in this was that New York City and New York State did not identify cases until relatively late in the early days of COVID. And I kept looking at that COVID map. As most of you know, I'm a recovering New Yorker from upstate, not the city. But looking at that map, and as a veteran of the New York State Health Department, saying, why hasn't there been a case in New York City or New York State? And then when it did appear, it appeared with a vengeance. And I think the rest of that story is kind of history. But it was interesting that it took so long for it to be identified in New York City and New York State. Pitt County's timeline begins on March 12th of last year, for the most part. We were working on this before that. I was following this from the point it appeared in the news in late December. But on March 12th of 2020, patient 0 was tested for COVID-19. At that time, it was taking a week to get reports back, lab results back. And his results did not return until March 19th. And that's the day we announced our first case and said that COVID-19 is officially here in Pitt County. Since that time, we've accumulated more than 18,000 cases and lost more than 80 of our fellow Pitt County residents to COVID-19. July of 2020, our community testing program was stood up. And through December, and I'm sorry, Dr. Hardy, if I have this number wrong, our Tammy Reese, our lab director, gave me this number. She said that we did 7,154 COVID-19 tests in that time span. If it's actually 9,000, that's even better. But we did a lot of testing through those long summer months and through the fall. And summertime, it was too hot. And by October, November, and December, it was too cold outside. So it was a long, brutal testing campaign for our staff doing this as drive-through testing. On December 23rd, 2020, we received COVID-19 vaccine at the health department and very rapidly began administering that to folks. We had sort of pre-selected a group that were eligible and highly motivated and willing to get their vaccines that close to Christmas. And then after Christmas, our vaccine program began in earnest. This is the epidemic curve for Pitt County. Pretty much to date, this is through the last week of March through March 27th. Of course, I always get the reports come out on Wednesday, so I'm always a week behind showing these to folks. But But this is our epidemic curve, and you can see from March, we slowly grew. By the end of June, we had our first long-term care facility outbreak. We grew after that through the Memorial Day and 4th of July holidays. And then we kind of leveled off. And this was most of the summer with our testing program. We stayed fairly level. And then boom, we had this big narrow spike. This was the ECU spike of late summer and early fall, or just late summer. And then we came back to kind of our testing baseline. And then by the end of October, we began our climb to our eventual peak in mid-January. And we have receded since then, sort of hitting a nadir or bottoming out about it, a week or so ago, and now with a small spring wave coming, which I'll show you later in some other data. Looking at this by race, early on, African Americans bore a heavy toll in COVID. There's around this time in the spring where I reported to the Board of Commissioners, and at one point in time, African Americans represented 56% of the cases in Pitt County. I'm happy to report that in the full measure of time that has decreased to more equitable levels of distribution. And you can see the red is African Americans, and that has come down as our case counts have come down. The lavender are our Hispanic friends, and that too, early on, took a while for them to get into this, at least get tested, but then they grew, had their bulk in the midst of this through mid-January, and they seem to be a smaller part of cases as time goes by. This is the epidemic curve showing congregate living, and again, starting in March, you can see here's that first outbreak of congregate living. This was kind of interesting that here in midsummer, we started to see activity in other places. A little bit of a spike that kind of matches the ECU spike, but that tended to tail off pretty quickly. At this point, we had good testing, good contact tracing in the nursing homes and isolation in the nursing homes, but we had no vaccine. We had sporadic activity through the fall, a little bit of a rise through our spike here, but then it dropped off. And you see that drop off really matches vaccination very well. And most of our nursing home long-term care facility residents accepted vaccination. And we have seen since then precious little activity in that. And this is probably partly why our death count is so much lower than we anticipated here in Pitt County, still standing at only 86 fatalities, because we were able to control the spread of this and keep the spread at minimum in long-term care facilities. When we look at data, I'm just going to show you a couple slides of the metrics that I follow pretty much on a daily basis. This is looking back at our Board of Health meeting in February. 1,400 cases over the previous 14 days, so about 100 cases, 101 cases a day, 7.6 cases per 1,000 residents, and 8.4% positive in our testing. We look at our Board of Health meeting in March. We were about half of that, 562, a little less than half of that, 562 cases over 14 days, 40 cases per day, 3.0 cases per 1,000, and down to 5% in our testing. This was our data from March 30th, and this was pretty much where we bottomed out for the spring so far. We're at 255 cases over 14 days, about 18 cases a day, 1.4 cases per 1,000 residents. Still at 86 fatalities, case fatality rate of 0.5. We're down to 3.3% positivity from a high in mid-January of 13.6 across all testing in the county. And I might add that testing, we're still doing most weeks in excess of 4,000 tests across all providers in Pitt County. And then here's our numbers today, still far better than they were before, but they have crept up. So we're up to 407 cases over the last 14 days. It's about 29 cases a day, 2.2 cases per 1,000. We are at 18,563 cases that we know of in total. So that's 10% of our Pitt County residents. We would estimate that 18,000 of those, that's 18,070 of those, or 97.3% of those cases are recovered. We still stand at 86 fatalities, and our case fatality rate is at the low end of the reference range of 0.5. So we are, when you look at this, and I've tried, I can't extract the flu curve from the state website, but if you look at COVID and compare the COVID curve for this year or last year and this year to a typical flu curve, COVID looks very much like a typical flu curve. And in most years, we get a little spring wave about the beginning of starts around the third week or so of March through the first week or two of April. And we get this little smaller shoulder wave of usually influenza B. And it looks like this year that spring wave is going to be COVID. Flu still remains very, very scarce in all laboratory testing that we have access to. So, as I said, we are seeing the spring wave of COVID. It's similar to the B wave. Flu and RSV both have been nearly absent this year in our Biden system surveillance data. Vaccinations. Vaccine is available to anyone at this point from any group wishing to be vaccinated for COVID-19. The Pfizer vaccine is approved for ages 16 and up. Moderna and the J&J, with the caveat that it's pending re-review with CDC, ACIP, and FDA, are both approved for ages 18 and over. Vaccine is available in Pitt County from the Health Department, from Vidant Health, from the ECU mobile vaccine team, from pretty much all the Walgreens pharmacies except the one on Greenville Boulevard near the intersection with Evans Street. And there are several other pharmacies that are doing vaccine now as well. I don't want to speak for them. Some of them would be in the federal program. Some of them are being supplied by the state. And we ourselves are looking at ways to take the vaccine to other locations in the community and not just keep it in the clinic at the health department. Our demand for vaccine at the health department is waning, and we are not filling all of the available appointments we have for vaccinations at the health department at this time. We did special populations are concerned with the COVID-19 vaccination program. Pitt County Detention Center, we were able to receive a transfer of 100 doses of J&J. This was probably 3 weeks ago or more now for the Pitt County Detention Center. We provided 60 of those doses to the Pitt County Detention Center for their staff to vaccinate detainees. And at this time, we are holding 40 in escrow for the detention center, again, pending review by CDC and FDA. Homebound individuals we have identified individuals through our community paramedic program and other sources who are truly homebound and can't get out to get a vaccine. And for those individuals, our Pitt County EMS folks have gone out and been our vaccine administrator with vaccine provided from our stock, and we've done those vaccinations with Moderna. So they would go out and do the primary vaccination and then come back and do the booster in 4 weeks. Meals on Wheels recipients, we recognize this is a mostly homebound population, population that's would have transportation challenges. And Dr. Shackelford from ECU is working with his group to reach out to get these Meals on Wheels folks vaccinated through his program. Vaccinations and historically marginalized populations. Pitt County Health Department's worked with multiple community partners to encourage and facilitate the vaccination of members of historically marginalized populations. We've done this through our on-site clinics where we've blocked specific blocks of time for groups of HMP folks. We've worked with folks and given them access to our scheduling tools so that they can make appointments for persons from historically marginalized populations. A couple of weekends ago, Dr. Hardy and her crew went out to Holly Hills Church and did a clinic there with Moderna, gave 70 to 80 vaccines there. She will go back on the 24th with her crew and do the boosters. And we have a clinic coming up this Thursday at Cornerstone Missionary Baptist Church here in town to do vaccinations there. We had planned to do that with J&J, but we will run that clinic with Moderna at this time since the J&J vaccine is suspended. The numbers, bottom line of the numbers as of 23:59 hours yesterday on the 12th or midnight yesterday, 46,157 first doses, that's Moderna and Pfizer, 40,277 second doses, Moderna and Pfizer. Combined throughout the county, 86,434 doses in total have been administered. 25.5% of our population is partially vaccinated. 22.3% of our population is considered fully vaccinated at this time. So if you put that together, and while there's some overlap between those who've had COVID and those who are vaccinated, that overlap is probably small. We're now pushing 30% or more, maybe 32% of folks in the county that have immunity to this virus from vaccination or the disease itself. So I think we are truly gaining on COVID in spite of our little spring wave here. And again, I always put the caveat in here. We do get the data from the federal vaccination programs goes into the state system, but I'm not sure of the lag, so I'm not always sure that that's in the numbers I'm reporting. So these numbers may actually be a little bit better than what we report if the federal data is not in there. Our COVID-19 response activities, and this is kind of the COVID retrospective for you all tonight. Media relations, I think we recognized early that we had to be engaged with media, and we did engage local media early and often, and have continued to do that throughout the pandemic. Early on, we hosted a press conference, a group press conference. I did several media sessions one-on-one with local news stations. Even did an appearance on the Talk of the Town show with Henry Hinton one morning early in this. And then we began our standing press conferences and media sessions, and for several months those were twice a week, and then they went to once a week. But now we pretty much every Wednesday I make myself available to the media where I review the data, hit them with some key points, and then take their questions on Wednesday mornings. We have issued multiple press releases and media advisories regarding COVID to the media, and I've written several letters to our community, and those have gone out through all of our media outlets to speak to our residents directly in regards to COVID. Our COVID-19 hotline, this was up and operational before the first case was identified in Pitt County. It's operated Monday through Friday with the exception of holidays. And I think last year we actually did do Good Friday in the hotline since it was so early. So that's been up and running for over a year. It provides information on all things COVID and is staffed primarily by our health educators. Testing, Pitt County Health Department has collected, as I said, 7,000 plus tests, might be 9,000 plus tests if Dr. Hardy's number is right. It's a community testing program. We're still doing some testing and contact investigation in special circumstances. We've also become involved in the Say Yes to the COVID test. I'm sure you've seen this in the news. This is a CDC NIH project being run at the state level by a group between Duke and Chapel Hill. We're in the process of distributing 40,000 test kits here in Pitt County. Each of those kits has 25 tests in the kit. And the idea is that 2 individuals per household will test themselves 3 times per week for 4 weeks. And it's available to anyone ages 8 and up. For children, it's suggested that a parent or guardian do the swabbing for the child and that they don't do the self-swabbing for their own protection. Isolation and quarantine guidance. We have provided countless consultations to businesses, government agencies, and individuals regarding COVID, isolation and quarantine. I'm happy to report we never got to the point where I had to issue a written order of isolation or quarantine during the entire pandemic. In general, people have complied with our directives to isolate or quarantine as appropriate. I did get a call from Sheriff Dance one Saturday afternoon when a couple they were familiar with broke quarantine, and her deputies followed them and returned them home. And she asked me, "Well, can you write an order of quarantine for these folks?" And I said, "Absolutely, Sheriff." I said, "But you still have to enforce it." I said, "Do you want to put these people in your jail?" And she said, "Well, not really." So we opted to strongly encourage them to stay home rather than to be out gallivanting, and they complied and they did test negative. So one of our early interesting stories from COVID. Other response, contact investigation and tracing. As mentioned before, we worked with ECU to create an on-campus contact investigation and tracing group. This is largely based with student health services and uses public health students, both graduate and undergraduate, to do contact investigation and tracing on the campus. We did at one point give them an embedded person from the CCNC surge staff program so that they had access to NC COVID and could put data in directly. We also worked with Pitt County Schools to create an internal contact investigation tracing group there. And again, with our CD staff and myself at times providing technical support to that group. And then we obtained additional surge staff through the state program for contact investigation and tracing and folded them into our internal contact tracing team. Vaccination, to date, we've given over 10,000 vaccinations, probably closing in on 11,000 vaccinations to the people of Pitt County. We work with Provident Health to help stand up the high capacity site at the Greenville Convention Center. And we are working with our community partners to reach communities of color and other historically marginalized populations. Do want to show you the case in vaccine equity. Got a couple of points to make, and then I'll switch over to the state website if that's all okay with you all tonight. I know we're running long on this meeting, but I think it's worth taking a minute and looking at that case and vaccine equity section of the state website. I want to mention a couple of non-COVID matters for the health department. With environmental health, as you heard, our new division director, Angie Manning, is settling in. On-site wastewater, which was considerably backlogged in some subdivision work, has got that backlog caught up and has worked through those. There's a wait time. Was there anything in processing time with these things? And there's a lot of give and take with these subdivision works, but they are on top of those things. Our food and lodging inspections are at 100% complete, so that's good news for us, both from a public health standpoint and also from a financial standpoint. In the near future, we will be bringing the mobile home park ordinance before the board for your review and updates. That ordinance has not been looked at in years and really does need to be updated. So at some point, I'm going to have Ms. Manning bring that to your attention and present on that perhaps next month for your review, and then we'll need to work through some updates on that. As mentioned, we're requesting 3 positions for environmental health, 2 for on-site, just to keep up with the log of work. The building boom here in Pitt County does not seem to be going away anytime soon, and we feel that we're going to justify 2 additional folks there. And then we feel that there's 1 person for special projects for pools, tattoo parlors, and other things that don't really fit into one of the project areas that that are typical in environmental health, but still things that they have responsibility for completing. The dental unit, as Marcia mentioned earlier, we anticipate replacing that unit in budget year 23, and she has asked me to provide an update to the commissioners on April 19th, and I believe that is in their agenda for Monday the 19th. So I'll be speaking to them at that point. So we get out of this. Stop the share, and then, Mr. Chair, with your permission, I want to bring up that equity, if that's all right with you.
Sure, move right ahead.
All right, let me bring up the state website. This has been dormant for a period, so it'll reload. So when you first look at this, if you look at the tab here, this is the state dashboard. There's case demographics. When you first load this, it'll load this at the state view. And so if you look at the state view, this gives you the case breakdown by race for the state, gives you the case breakdown by ethnicity for the state, and then gives you the case breakdown by age for the state, and then by gender. So we still, in cases, we see a female preponderance, and that holds up in our county data as well. So let me show you the county view of this for Pitt County, show you where our cases stand from a distribution standpoint in Pitt County. Okay, so here's our Pitt County racial data. American Indians, Alaska Natives, we actually have 1% of our cases amongst them. Asian Pacific Islanders, we have 43 cases, that's why it's in parentheses, but not quite enough to register as a whole percentage point. African Americans actually just took a tick up today to 17%. They had held steadily at 16%, probably for the last couple of months. Whites represent 64% of our cases, and 18% are defined as other in that case demographic. When we look at ethnicity, Hispanic individuals represent about 9% of our cases in the county at this time. This is total. You can see this on a week-to-week basis. Look at it week to week. and then by age. And this has been pretty stable throughout the epidemic. If you add up underneath, we're at about 12%. So 3, 4, 3 is 10, 11, 12% are in the school age group and preschool age group. And then our two biggest groups are in the college and graduate, typical graduate student age group. That's the 18 to 24-year-old age group, and then the 25 to 49-year-old age group, sort of that young adult worker. So it's really young. It's older adolescents and young adults and young working adults. It's really where the fire of COVID is burning in these two groups. We look at our 50 plus groups. This is where our deaths have occurred, with most of our deaths being in the 75 and over age group. The age adjusted mortality is very striking. Last time I did it was about 8.5% if you're at 75 and older. So fires burning in the younger age groups, fatalities in the 50 and over. And in our county data, female cases outpace men by 12%. One of my potential explanations for that is that we do have a lot of female healthcare workers who may have been subject to infections in the course of their work. So that's just kind of a quick look at our case breakdown by race and ethnicity. Show you our vaccination data. And so this brings up the summary data for the state. If you look at this, 74.2%, or at least partially vaccinated in that 65-year-old group. 68.6% are fully vaccinated in the 75 and older age group, or 65 and older age group, excuse me. I think that's good news. This is where our highest risk of death is. Those numbers get a little bit smaller as you move down. Look at the demographics here, go to the demographics view. And this is the state view. So for vaccinations, African Americans lag about 6% behind across the state in terms of receiving their vaccine. Asian Pacific Islanders are actually a hair ahead in receiving their vaccine. Whites are about where they should be, just a hair, actually a hair behind, 0.3% behind their proportion of the population. Excuse me. We look at our Hispanic friends. I think this is the graph really shows us we've really started to make some inroads with Hispanics in the last couple of weeks across the state. 9.8% of the state population is estimated to be of Hispanic origin. Vaccinations right now about 5%, 5.7%. So just a hair, 4.1% behind across the state in terms of Hispanics in terms of their receipt of vaccine. That's the age table. That makes me dizzy to look at that. This can also be looked at on a county by county basis. And when you go to Pitt County, sorry, it's so slow loading. The computer's getting tired too. Native Americans and Native Alaska is very 0.4% versus 0.6%. So fairly close there. Asian Pacific Islanders, fairly close. African Americans are lagging in vaccinations. They're about 8 points behind where they should be. But I'm encouraged when I do wander through our lobby during vaccine clinics, I see a number of African Americans coming in at the health department to get their vaccinations. So I'm hopeful that they will catch up, but we are 8% in the county, about 8% behind across the African Americans in the county. Whites are slightly ahead of where they should be, 60% versus 61.8%, about 2 percentage points there. When we go to Hispanics, we've actually ticked up a notch with Hispanics this week to 4.4% vaccinated versus an estimated 6.5% of our population. So about 2.1% behind where they should be. And I think the graph tells it nicely. I think early on, the dark blue is Hispanic folks. these probably represented healthcare workers early on. And then as we got into the older age group, small proportion, you can see we've started to make inroads with them. And really in this past week, really have started to make some inroads into that Hispanic community, that they're starting to come out more for the vaccine. So I think we should be able to close that 2 percentage point gap there. Again, the age table, that kind of makes me dizzy. So, but just wanted to walk you through that. This is a Tableau data platform that the state has, I think very useful in terms of visualizing the data and understanding the data from a number standpoint and a race and ethnicity standpoint. And at that point, Mr. Chair, I will stop and I'm happy to take questions.
Thank you, Dr. Silvernail. Any questions from the board members?
Dr. Silvernail, this is Nitesh. I want to say thank you to you and your staff for all the work that you do and continue to perform. In regards to the vaccine, getting these shots in the arms are just so vital. I was just wondering, though, when you're in a situation when a dose is about to expire in the 2 to 6 hour window, what measures does the staff do to help minimize the waste?
We are very careful about scheduling to start with. So the Moderna comes packaged in 10, so we try to book in groups of 10. With the Moderna, there's a fairly reliable overfill. It's maybe every second or third vial has at least one additional dose in it. So we do have that. We did create a running list of county employees who wanted it at one point to get it. We had one of our paramedics when we could not get people to come in and get vaccine. He said, well, I know some folks in the neighborhood who want it. And we sent that individual home with, I think it was 3 or 4 doses of the Moderna. And he actually went around his neighborhood and gave out doses. Dr. Hardy has done the same thing in her neighborhood. She's taken vaccine home with her and administered it to neighbors. I think she went to a nail salon one night to administer some there. It has become harder to get to the point where we are not wasting vaccine. We still, knock on wood, have not wasted any of the Moderna vaccine at our clinic. But we have gone to great lengths to do that. Dr. Shackelford, I forget if it was with our vaccine or his vaccine, because he gets some through ECU as well, actually went to a Piggly Wiggly and sat in the parking lot of Piggly Wiggly until he could give away his last 2 doses after an operation down in Aden. So we have gone to great lengths to try to reach out to folks, to maintain lists of folks that are willing to be vaccinated. Now with everybody being eligible, the sort of that waiting list has kind of gone away. So, but we are careful in scheduling and counting and trying not to open a vial to give a vaccine unless we really have to, and we know we can use that vial.
Right, sounds great. You guys are doing a wonderful job, and just want to say thank you again.
Thank you for your kind words, sir.
Other questions or comments for Dr. Silvernail?
John, so just to echo, just incredible job over the past year you and the public health team have done. You should be commended and appreciated. The Johnson & Johnson thing is something. I agree with you. In my career working in emergency departments for almost 50 years, I've not seen a case of a cavernous sinus thrombosis, but it only occurs in 3 or 4 people per million population. And this rate was actually lower than that. I think it shows the value of the vaccine adverse event reporting system, which sometimes can be underreporting. I was just wondering if you would comment on, as a health director, where you think this thing is going to go with the Johnson & Johnson vaccine, and what we might do to promote vaccine, getting the vaccine despite some hesitancy that might be reinforced by this issue.
That's a lot there, Herb.
Sorry.
Dr. Garrison, excuse me.
Sorry for the late hour for such a question.
There's some folks that we certainly know that there was a preference by some individuals for the J&J vaccine in terms of wanting that one shot and being done with it. There was some hesitancy recently with I guess a manufacturing mistake where an inactive ingredient was put into a batch that was not approved by the EUA, caused a little bit of a mix-up, and that vaccine had to be discarded. And then the incident at Wake and Orange counties last week, which the CDC put out a memo with some, what were probably vasovagal reactions, those sorts of things to the vaccine. And I will say that we haven't seen those things ourselves with both the Pfizer or with the Moderna, and we did our J&J clinic. I think we had one person that felt a little funny after the vaccine. Was not a large number by any means. This, as I said, when you look at this 6 and 6.85 million is about 0.87 per million. So a pretty low rate of this. It's interesting that there were some thrombotic issues with the AstraZeneca vaccine, which is not currently approved in the U.S. That's also a viral vector vaccine, a chimpanzee virus vector vaccine. So there's some concern that this is this prompting this, promoting this sort of autoimmune thrombotic event. Are these just random events that have been caught that might have happened anyways, and whether the person had been vaccinated or not? It's kind of hard to sort that out. I think it's interesting that they're all females. They're all females of what would generally be considered reproductive age. 48 is a little late for reproductive age, but average age of menopause is still 51. So conceivably, those are women with higher estrogen levels, maybe more prone to thrombotic events. There's also no mention of whether these 6 women were smokers, whether they were on oral contraceptives or other oral estrogen products that might have increased their thrombotic potential. So I think we've got to sort through the data. I think it's reasonable if we've had this sort of bizarre occurrence come up in the monitoring, that it's okay to pause it and look at it, take a good hard look at it, and make sure that it isn't something that's going to be a problem going forward. Sorry, I lost my train of thought there a little bit. In terms of bringing this back out, do you bring it back out with a caution that this might be a symptom of it? Do you exclude that group? Do you more closely monitor that group? Potentially, I see those things happening going forward. In terms of the confidence in these things, the other thing that you have to realize is, when you do your clinical trials, there's that pre-marketing and marketing experience, and then there's post-marketing experience. And when you get to numbers this big across the nation, I think across the nation, was it 6 million or 60 million doses given? I forget the national number. I kind of following the local numbers. When you hit numbers that big, even the tiny percentage side effects start to appear just because the numbers are so huge. The statistics catch up with you. But when you talk about 6 people having this serious blood clot event and one of those dying of this blood clot event, that makes the news. It doesn't make the news that the risk is really 0.87 in a million of that happening. So hard to get around that sometimes to the average person.
Thanks.
You're welcome, sir.
Other questions? All right, well, it sounds like we got some homework to do based on Ms. Hardy's report, and I'm sure there's going to be more to follow on that. If we don't have any other business to discuss, we'll look for a motion to adjourn.
So move.
I'll move to adjourn.
Second.
Any opposed? All right, we'll see you guys next month. Thank you so much.
Good night, everybody.